so some slides will be the same. I really try to skip or to go very fast through some of those slides which have already been exhaustively explained. Just quickly before jumping into the surgical issue itself, I would just like to emphasize once more the magnitude or the extent of the obesity epidemic, we may call it POM epidemic, which we are dealing now at this moment. One of the first important statements that I have put here, I just put 4 statements that have to describe a bit the importance of that obesity epidemic, is that the global health problem of overweight is seemingly equalizing that of underweight. You have to listen carefully. I mean, this is a very important statement. And it's estimated to occur in 1 billion people. 1 billion people. So the problem of underweight, with all starvation, what you see on television is certainly also reality, but now the reality of obesity is nearly equalizing the problem of underweight. Don't you believe that? How far we are going? Secondly, obesity will overtake tobacco as the leading preventable cause of mortality. You have already mentioned that statement as well. This is now passed away. I mean, it is now more becoming important. Those slides are from some years ago, are more important than tobacco as the preventable cause of mortality. How important it is. And then the related healthcare costs account for 10% of the total United States healthcare expenditures in the United States. So 10% of the total budget going for healthcare is just going to treat obesity and obesity-related diseases. 10%. And then also very important, because still I'm a surgeon, none of the measures that have been undertaken show any sign of helping or reversing the problem of obesity worldwide. Here you can see the evolution of the obesity, so it is certainly not just a Middle East phenomenon that we see in Belgium, where you can see that just in 2 or 3 decades there was nearly a double increase in the incidence or the prevalence of obesity, as you see. It started mid-70s, and you can see that both for men as well as for female patients, there was a very steep increase in the incidence of patients with a BMI of more than 30. That's not morbid obesity, but anyway, a lot of those patients will develop morbid obesity later on as well. Here you see very briefly the history of the bariatric surgery. So just very shortly and briefly, the early attempts have been performed or done in the 50s, and there were jejunal ileal bypasses without a very good success. And then in the 40 years, I think the first bypass was done somewhere in the 70s, until the early 90s, we may say that bariatric and metabolic surgery, I don't think they ever talked about metabolic surgery in the 90s. Anyway, it was still a very unpopular specialty. But if we look then, just 15 years later, between the domain of general surgery, it has become one of the most popular specialties. And a lot of surgeons now are jumping into that field, for whatever reason. I leave that behind. But anyway, there have been 3 major contributions to that success. First is the public awareness of the importance of obesity and its relation on the healthcare. The second is the laparoscopic access, the surge of the laparoscopic access, which has certainly lowered the threshold to go for surgery, both from the point of view for the patient, for sure, but as well from the point of view of the surgeon. And I think the third main reason was the reported success ratios, which were coming in, and certainly even between 2005 and now, there have been so exhausting and overwhelming evidence now what is the benefit of considering bariatric surgery in the group of patients who are morbid obese. And it has now become a popular procedure that also now we are considering to do not only those type of surgical procedures for the problem of obesity, but also for the problem of diabetes, type 2, hypertension, hypercholesterolemia, and whatever. So this is also one of the reasons, because I'm president of the Belgian Society, that we have changed our name. And we just not only mention the name bariatric, but it's now the Society of Bariatric and Metabolic Surgery. So we're taking both in one name. But in spite of that popularity, I think we may say that there's still a lot of questions, doubts, criticism regarding bariatric surgery. And one of the first is that obesity is still, I think, considered too much as a self-inflicted disease, a behavior problem where surgery will not provide a structural solution. And secondly, in relation to that, obesity surgery is then also sometimes related to a lifestyle surgical procedure, and even worse, to a cosmetic, a plastic surgical procedure. Also very important, and that's a bit of a handicap for us as surgeons, it has not been defined yet on whom we may operate, by whom, which type of the procedure is now the most ideal one, and still we get the question, the following statement: do we have to offer our patients a surgical treatment at all? If there is budget for that, if I hear from Bulgaria, there's not too much budget for that. But anyway, we come to that a bit later. I think we have to do so. So we still have to question: is it all worthwhile? Is it all useful to do so? If you look to this picture, you see that being obese or even being super obese is not always opposed to happiness. It's not always opposed to jump into a marriage. It has to be a relatively big boat, if I may say so, to jump in for that. But anyway, you see that you still can be happy. But in contrast to that skepticism, in contrast to those questions and doubts, you have the facts. First of all, very important, obesity is a serious disease with an important impact on the quantity of life as well as an important impact on the quality of life. Secondly, drawn from a lot of scientific studies, conservative treatment options do not provide a sustained weight loss in the long term. That's a fact. And thirdly, also drawn from a lot of scientific reports, surgery do remain the only effective treatment for patients with morbid obesity. With a weight loss, which is sometimes dramatic or substantial, the comorbidity control is also very substantial. And what we see on a daily basis is that the patient satisfaction, if you operate somebody for obesity, is greater than for any other general surgical procedure that we do. And so this is certainly also for us surgeons, I think, a nice thing to be confronted with. If we look at the laparoscopic procedure as a whole, we have three major groups. We have the groups of the restrictive procedure, which is those procedures with the most important aim or purpose that the patient is going to eat less. You have the intragastric balloon, which is not a real surgical procedure, but has the same aim that the patient would eat less. One of the problems with the balloon is that it has to be removed, let's be very honest. Now we are developing a balloon for 1 year. The only indication that I still see in an intragastric balloon, probably in contrast to our gastroenterologists, but anyway, those super obese patients with BMI of more than 60, which are not ready to go for surgical procedure at once, I think there's an indication to either to place an intragastric balloon or either really put them on a very, very strict diet. The other more restrictive procedure that are surgical is the laparoscopic band, the VBG and the sleeve. Although I have to sleeve that the sleeve is not a purely restrictive procedure, also have a very important hormonal effect because you remove the stomach. And on the opposite side, you have those procedures which are completely malabsorptive. The scopinaro and the duodenal switch. We have to say that in Europe now those procedures have lost a lot of the interest. We did also a lot of scopinaros in the past, but we have to say frankly, I'm afraid of it that those procedures are a bit too metabolic. They work too hard. Patients developing a huge percentage hyperproteinemia, hypovitaminose, etc. And also there's a loss of quality of life in terms of going to the toilet. And in between that, you have the procedures which combine restriction as well as malabsorption. This is called the gastric bypass procedure. And I think that worldwide, at this moment, I think the gastric bypass has become the golden standard in between the different types of surgical procedures. Anyway, we still are confronted with the fact, which procedure do we have to choose? And I think this answer, or this question is still not being answered. What we have to take into consideration is that we have to know, and we have to say that to our patients as well, that there does not exist something as this is the one unique super operation. That does not exist. We always stress now more than we did in the past because we know that there's going to be failures. Also after gastric bypass, even after a duodenal switch, surgery just remains a tool to lose your weight, a means to lose your weight. It's never going to be the end point of your obesity problem. Secondly, the success ratios are never 100%, even not with the DS or with the scopinaro. Every procedure has specific advantages and disadvantages. Also very important to know, certainly we as surgeons who are really confronted to see the patients, the bariatric surgery is still in development. It is a relatively recent surgical subdiscipline. If you look now that the sleeve is coming up, since 10 years now everybody's starting coming from Iran of gastric glycation, and now with gastric glycation we're putting a band on top of that. The thing is that's at least my conviction. If we have to offer a patient something, there has to be some scientific backup which is lasting longer than 1 or 2 years. I cannot defend to say to my patient, I'm going to do gastric glycation, but somewhere in the world they do that, and it seems to be okay. at least, you know, there have to be a much more important scientific backup, where I would consider to offer my patients something which is either temporarily, either doesn't work, or whatever. That's important. So, but then at least as well, one of the important considerations that unhappily, the patient characteristics do also play a very important role and will define a bit the final clinical outcome in terms of weight loss. We can do a fantastic procedure, but we are no neurosurgeons. We have to know that. Sometimes there will be patients, although they have been very well counseled before surgery, after surgery, we're going to have failures. And sometimes I say to my patients, when I'm a bit, if I may say, pissed off, when patients are coming back, you know, doctor, you have helped me, they have already 3 procedures in the past, then sometimes it's better to send the patient to the neurosurgeon, you know. We not can win every fight, you know, we'd say so, and sometimes we're going to have patients, although we had a very good counseling before surgery, they're going to script the good result. What I think is very important now as a surgeon is that we have to tailor the type of the procedure towards the type of the patient. We are taking into account not only the BMI, the body mass index of the patient, but also the eating or drinking behavior of the patient. If it is a sweet, is it a binge eater, is it a volume eater? We have also taken into account the age of the patient, the comorbidity of the patient. If the patient has Crohn's disease, we certainly wouldn't have to go for gastric bypass. So we have to tailor those things. And also, unhappily on the field, we have to say that the patient preferences will also play a role. Although some patients are coming to us and say, doctor, we're just willing to have a band placed. And he or she has a BMI of 40 with diabetes, I say, Jesus, I mean, you're going to be much better off with a gastric bypass. And we really try to convince them. But if they are not willing for whatever reason, because they think it's too invasive, because of the small bowel or whatever, I still think that it's still better to place a band, if you look at the studies of Shustrom or whatever, Dixon or Bryan, than to offer nothing. We still then have to consider that the surgical procedure and some of this morbid obesity diabetes will be better than non-surgical procedure. But we really try to convince the patient that we think is the best procedure at this moment. But what we have seen certainly in Belgium is that the surgeon preferences have played a too important role. It's very easy at your consultation to promote one type of procedure above another. And we have to say frankly that certainly 10 years ago, we had a lot of bariatric surgeons in Belgium who just could place a laparoscopic band and didn't have any skills to go for, the sleeve was not existing then yet, to go for the bypass or a more invasive procedure. And then patients would come with a BMI of 55, diabetes, a lot of comorbidities, and the patient was saying, yes, I come for a surgical procedure, we will do a laparoscopic band then. But the patient didn't have a second chance of checking choice, because, you know, the surgeon had not that acquired skills to do another more advanced surgical procedure, which certainly would have been much better in that type of patient. And I think this also happened in a lot of other countries, in Europe, and probably also throughout the world. Okay? The band, I'm not going to discuss that now extensively. I think we had already done that previously. I think the VPG has been mentioned as well. We did 2,000 laparoscopic VPGs McLeans in the past. I may not say it's a bad procedure, but one of the real problems that we have seen at the lower end, it's not the weight loss. The weight loss, if you look to the study of Buchwald, is quite comparable to that of the gastric bypass. But one of the problems that developed is what we call gastric outlet obstruction, and here at that level. So patients are starting to develop reflux as a variety. They could not eat or drink anymore. And then either we had to just cut that drain, either so that if the patient is still obese, or once again obese, we consider to do the conversion procedure to a gastric bypass. And then we have the sleeve gastrectomy. You have already heard from Dr. Kalipa and also Michel Garnier, who is one of the founders, if not the founder, inventor of the sleeve, but as an initial operation for duodenal switch, I have to say, not as a primary procedure, standalone procedure in the beginning. It is becoming a very popular method. We can discuss that afterwards in the debate forum here. We are still relatively restricted to do that on a broader scale. We still have to wait for the longer term results. And like I said, the thing that I really don't find so pleasing that you really actually remove such a big portion of an organ, namely the stomach. But once again, there are advantages and disadvantages of every procedure, and we can discuss that a bit later. Regarding gastric bypass, as I said, they started in the 70s. All types of gastric bypass have been described, but I think now internationally we say that the focus of the operation is to make a smaller gastric pouch and then to divide the small bowel at the level, let's say 30 to 50 centimeters from the ligament of Treitz, then to pull up number A of the small bowel, make a connection by whatever means, is it a circular one, is it a linear one, or a manual anastomosis, and then much later we take 1 meter 30 normally, but as I said, sometimes 2 meters, then we're going to re-establish the intestinal continuity a bit later. And we are pulling up the small bowel, as you have seen in a live procedure, anti-colic, anti-gastric as well. Now, how does a gastric bypass work? Very briefly, but I think interesting. I think, like Malfoy and some famous surgeons, much more famous than I am in the world, we still have to consider the gastric bypass as a mainly restrictive procedure. Mainly restrictive procedure. Because when you see failures of a gastric bypass and you listen to the story of the patient, they're going to say to you, we have lots of restrictions. We once again can eat too much hyperphagia, either they can eat too frequently polyphagia. That's the real confrontation. So the restriction got away. Either because the pouch size have dilated, either, what I think is certainly much more frequent, the gastrointestinal anastomosis got wider. Anyway, they say there is no blockage anymore, they do not have any sensation of fullness anymore, it got too much easily down. This is important. A lot of studies focusing on the malabsorptive part of the gastric bypass are showing that the serum albumin and fecal fat absorption is normal. The glucose uptake in some radio-labeled studies is also seemingly normal. There are no real good PubMed publications that are showing any important malabsorption of anti-cancer agents, which is very important after doing a gastric bypass. Once again, the proximal type of gastric bypass, not the distal one, we're talking about the proximal bypass. And also very important, the weight loss, and I've explained that previously, the weight loss is seemingly relatively independent to the length of the elementary limb. So the malabsorptive part is probably not so important. If we look now to the hormonal part, I think this could be a very important issue. And we're not going to discuss that now in depth. Why? Because I'm not specialized in that. That's very easy. I think that, and probably Dr. Doreen knows it much better, the gastrointestinal tract is the biggest endocrinological organ. More than 20 hormones have been produced. And what we certainly know is that ghrelin, which is certainly a very important appetizer, is going to produce much less after a gastric bypass as well as after a sleep. You have nice studies, and I think Dr. Khalifa showed one of those studies as well. But also GLP-1, which have the opposite action, as well as PYY, very important hormones. You know, they're normally going to suppress the appetite. They're going to be induced much more earlier and faster when the patient will eat. So anyway, I think that the hormonal effect, certainly also the working on diabetes, etc., is probably also very important if you look to the benefit of the gastric bypass on the longer term. But I would just like to conclude that, first of all, surgery remains, or do remain, the only effective treatment for morbid obesity. The gastric bypass represents the golden standard between the bariatric surgical solution or options, with the most sustained and the most significant reported weight loss, the greatest impact on the improvement of the associated diseases, and also, I think, the best preserved quality of life. But I certainly am convinced as well that a high surgical skill and a steep learning curve are essential in keeping the operative time and the complication rate as low as possible. And I would like just to conclude with this slide of a patient of our city, Dr. Torre, knows this city, Brugge, as you see here. This patient was begging me, because he's a very important supporter of our football soccer team, Brugge, that they would make the incisions just around these tattoos, as you can see here. This is the belfry, I have to say. So I made my incisions, I think I was aware of it, but I cannot show you the picture after 1 year, because the belfry is not standing anymore, it is now more the Tower of Pisa, so it is certainly not as nice as it was before the surgery. I thank you very much.